So if you would please join me in a warm welcome for Dr. Dan Johnson.
Thank you, Ray. So one of the things I do is I don't like to have barriers between me and you, so I'm going to move this, and hopefully everything won't all shut down. All right, does that work there? All right. So I may walk a little bit. I'll try and keep the mic in front of me if you can't.
Turn that so that the speaker faces.
Like that? All right. If I start dropping so that you can't hear me, just give me a thumbs up and I'll know that I need to speak up a little bit. So when Ray first asked me to do this, I was talking with you guys maybe a couple of years ago up here for a little different session. And when Ray asked me to do this, I started thinking about, what might most be helpful. And I specifically don't have a screen or slides because my experience is this type of discussion doesn't lend itself very well to a bunch of slides. And I actually care an awful lot about what you guys are thinking, what questions you have, and what you're worried about. So in that sense, today is going to be entirely interactive. And that means your part of this is I expect you to interact and not be afraid. To stop me, to challenge me, to raise your hand, to say the question that I really have that's burning right now is this. And we'll try and address those right in with all of the work we're going to do. I'll share with you that what we're going to try and do today is through two cases, through two situations of patients that I have cared for, we're going to look at those and see how these religious directives interact with these patients and their stories, and try and understand from that what the intent behind the directives are and how those directives from a practical standpoint play out. Let me share with you kind of why I'm here. So I'm a physician. I trained as an internist and I worked in primary care for a while over at the University of Colorado, and then I became interested in this thing called palliative care. And one of my goals is for those of you who may not know what palliative care is, I hope many of you do, by the end of today's session you'll also know a lot more around palliative care. It became a formal specialty in 2006, and now there's physicians all over the country who train specifically to learn about palliation, which means to ease or relieve, and how we might attend to human suffering, especially in the context of advanced and end-of-life illness. And so I spent years training to become more effective at how I can link with patients and families. I work on a team that consists of a nurse, a physician, a social worker, a chaplain, and a pharmacist, and I'm at the two hospitals that Ray already mentioned. And we provide support for patients and families who need or want support as they're facing some of the challenges with progressive illness that often can't be cured, and they need help in figuring out, well, what do we do next? What's available in the community? How do I make that decision? Do these therapies make sense or not? And how do I kind of sort through that? So I want you guys to be aware of those services because it's really important to know that anytime you need access to those services, increasingly now they're available. I want to share with you some caveats. I'm not an expert in the directives, so if anybody here is, please raise your hand and feel free to share. I'm going to read to you excerpts from the religious directives themselves, and I'm certainly going to share with you how those are being applied at the hospitals. In other words, what's actually happening. Because I hear lots of stuff in the media and all this myths and misperceptions, and the truth is those people aren't in the hospitals doing the work. We are. And so I can tell you what's actually happening and how those directives apply. I'm also going to share with you that I'm not Catholic. Now that really doesn't matter, and the reason I share that really doesn't matter is if I look at the physicians alone on the teams that I just described, those palliative care teams, and any of the hospitalists for that matter, we have the full gamut. People who are atheists, people who are Buddhists, people, you name it. We have just about every religious preference. And across the clinicians in these hospitals, the same thing. It's not like everyone working there is Catholic. So I share that with you just to suggest to you that this is a much broader issue than just Catholicism. This is about how we apply care in these hospitals. And that's what these cases are going to try and highlight. Okay? So any questions before we get started? One of the things I want to share with you guys is I want respect for people as they're talking and for people that are expressing wishes. I realize everyone's wishes here may be different in the room. And so let's honor it by making sure that we hear everybody out and be respectful and not interrupting, things like that. I don't expect any problems, but I just wanted to share that with folks. So any burning issues before we get going? All right, so let's read the first case and let's see if we can spark this room up. By the way, the 3 goals I have today personally are: 1, I really want to talk about the directives in the context of what's actually happening. 2, I want to talk about this thing called medically assisted nutrition and hydration, or artificial nutrition and hydration. It gets a lot of press in the literature. I want you to hear it from a palliative care physician and people who are in the trenches working with this stuff every day. Yes?
I think there is a burning question of how we got here and what Kaiser's position is.
We will address that.
We will?
Absolutely.
But you're talking about the directives right away.
So one of the things I'm hearing you would like to hear is what Kaiser's position is on this.
How we were
And
put in this position.
the history, the politics behind.
And why Kaiser didn't resist. A lot of us were at a secular hospital, namely Boulder Community. And then involuntarily, Kaiser moved us, against many of our wishes, I'm sure,
So what I will not...
to a hospital that
Gotcha.
you didn't cause it, but it later became sectarian.
What I will...
Why should we have inflicted on us a sectarian hospital?
I understand. Let me make it clear. I apologize that this will not meet your needs today. I am not here to try and talk about the history of why Kaiser or why Exempla is where they are today. And the only reason I say this, I'll share with you my perceptions, but I'm not the expert. I'm not the... Go ahead.
Why doesn't it behoove Kaiser to let us have a secular hospital?
So again, the question for all of you in here is, why doesn't Kaiser have a secular hospital? And the truth is Kaiser does right now have access to the secular hospitals. We provide care at most of the Health One hospitals in Denver right now. And that story, as you know, will continue to change. But again, I think I would do a disservice to not address kind of the things that we've talked about here. And then I will certainly tell you my perceptions around the way in which Kaiser approached this, but believe me, I could never answer the question I think that you want answered as I hear you state it, because I was not involved. I was not in that history at all. And I seriously couldn't even answer that question probably to your liking. But again, I'll share with you my own perceptions. Yes?
I guess my biggest concern is going forward. We are where we are, and going forward, Kaiser won't tell me, well, what is the difference between if I were admitted to Boulder Community or admitted to Exempla? And that's really my bottom line. It's how my life changed.
And I will absolutely answer that question.
That's what I want to know.
That's what I want to focus on today, actually, is I will let you know what's happening at these hospitals, and I'll compare it with what's happening at other hospitals. All right, so let's move forward with this case. And again, I expect many more questions, and I encourage those questions, and I'll do my very best to answer all of them. Mr. G, patient case 1, is a 28-year-old male who's admitted, by the way, I changed some of the names and some of the details to protect these patients. He was admitted to the hospital with severe swelling in his face. He was breathless, and he was confused. The patient has a history of lymphoma, which is a cancer of the lymph system, which was diagnosed and treated 10 years earlier. More recently, he has an incurable mouth cancer that unfortunately resulted from the radiation treatment from his prior lymphoma. This is not uncommon, and this is a really sad situation, especially in a man who's 28 years old. He has fatigue, he has weakness, and at home it's becoming much more difficult for him to do anything except stay in bed. Mr. G now is mostly bedbound and has little or no appetite, where he takes little or no food or water in on most days, resulting from his advanced cancer. To help him breathe, at a prior hospital visit, a tube was placed in his neck. That's called a tracheostomy. And he's had that for several months. That helps him to breathe. He can still breathe through his mouth, but it turns out that breathing through that tube makes it easier and more comfortable for him. The patient lives with his parents and multiple siblings. And I'll share with you, he's not a Caucasian white American. He has no prior advance directives, but has requested on multiple occasions that his father make all the medical decisions for him in the event that he could not speak for himself. Tests reveal that he has something called superior vena cava syndrome, and what that is sometimes tumors can block the drainage of the blood back to our hearts, and wherever that blockage is, it can cause swelling. And in this case, the blockage is in his neck, and it causes swelling of his face. So when you were to walk in the room, you wouldn't even recognize this as a young boy because his face is so swollen and his lips are swollen. And it's a very sad, remarkable when you meet him, physical kind of appearance. He also has something called sepsis, which is an infection in the blood. And oftentimes when people have sepsis, they can be very, very sick in the ICU, on machines, on chemicals that help keep them alive because their blood pressure often falls to the point where they can't sustain life. He has started requiring urgent medical treatment, including antibiotics, medications to support his blood pressure, and breathing support through a mechanical ventilator, where they hook the mechanical ventilator up to that tube in his neck. He is receiving artificial nutrition through a tube in his stomach and IV hydration through an IV in his arm. After 10 days of aggressive therapy, which was what his dad had said that he would want and his family had agreed, and in concert with the medical team and the family, they make the decision to withdraw life-sustaining therapies. Specifically, the father states, "I want my son to die naturally. None of this is helping. In fact, it's harming him, and I don't want it anymore, and I want to stop the therapies." So, my first question, is it ethical and or legal to remove life support, including medically assisted nutrition and hydration, from this patient? And is it ethical or legal to deny this family's request, which, as you can see, is the pairing question. That's the question that needs to be asked on both sides. And so I'm curious what you guys think. How many of you, let's just do a show of hands. There's no right answer here, although I'm going to share with you what I think are some clear distinctions that we do know. Is it ethical to remove life support from this man? If you say yes, raise your hand. Is it ethical to not remove life support from this man? So a much smaller proportion thinks it's ethical to not remove life support.
In the
face of everything I've described.
Yeah.
Yep, exactly.
Yep. Dan, I stuck my hand up because there is an ethical basis for not removing the life support. So it's not, it's a question of, what we're really asking here is preference, not, a moral decision.
Good. Yes. So the patient's not able to speak for himself. What we have is a father who says that in the event my son could speak, this is what he would say. That's called substituted judgment. Yes?
Is the patient able to respond in any way?
The patient is able to, he is aware that people are present, but he's not able to communicate. If you ask him simple, even yes-no questions to, do you feel my hand, do you feel any pain, he can't respond. So at this point, we have no way of getting his position on this.
So I think his point was a good one of preference versus, but in fact, there is no cultural ethic. We like to think there is, but it's very individual. So I would imagine everybody, as I did, said, according to my ethics, yes. But I don't know how you were posing the question.
Does everybody understand the point that was just made?
If you wouldn't mind, Dan, to repeat a part
I'll do
of
my
the
best to
question.
repeat the questions. She was much more eloquent than I can be. The idea around an ethic, is there a cultural or societal ethic here? And the answer is that's a tough one, because most of us, when we answer these questions, are going to be answering them from our own individual ethic. And the idea that I could see different responses across this room does not surprise me at all. When these cases hit the courts, if these cases were to ever make it to the courts, what we learn is sometimes the courts have to then try and decide, at least for a snapshot in time, what the societal ethic that underlies what laws might be created might look like. But even though, recognize the fallacy of it still doesn't get to the issue of what is people's individual ethics here. What does the law say? Can I remove life support from this person who his father is speaking for him, saying he would not want any of these life-sustaining therapies anymore? Can we stop them legally? You bet we can. This has been studied in the law, multiple cases now across many states. There is no question that any capable person or a person who is speaking for that person because they're not capable for themselves can make the decision to refuse any life-sustaining therapy at any time, any medical treatment for that matter, at any time. That's well established. So the idea of refusing the treatments here is not in question in terms of the legal aspects. Yes?
Even if they don't have a living will?
What about if they don't have a living will was the question. What if it's just the father talked to his son a while ago, or maybe the father never even talked to his son and he just thinks this is what his son would want. What do you think about that? Is that enough? That's enough. You bet that's enough. So the place where it gets a little bit tricky, and we're going to talk more about this, is with medically assisted nutrition and hydration in a person who is otherwise not dying. So for example, a persistent vegetative state, and it depends on the state in which you are in. State laws sometimes get a little bit grayer in that zone when a person is not speaking for themselves. But for everything else we've been talking about so far, which is in this case a man who wants off of these life-sustaining treatments, we have enough information to know right now that from a legal standpoint, we could be supported to stop these therapies. From an ethical standpoint, it depends on your perspective, but I'll tell you in the literature around the ethics of these situations, this type of situation is not debated at all. It is generally considered ethical to honor patient and family autonomy in the event that those therapies, in fact, are not meeting meaningful goals for that patient or that loved one. Yes, so let's go here
Is there
first.
a way to find out from, maybe he changes his mind and he decides he wants to live right before he's going to die. Is there any way to read his mind waves or anything?
Okay. The question was, is there any way to read his mind waves? And the answer is, I wish. It'd sure be nice to take families out of the conflict they sometimes feel when they're not sure what to do. The truth, though, is that most of the time, there are pretty good studies that show for elderly patients, and we haven't studied this in a younger man like him. Elderly patients have shown in repeated studies that they want their families to understand their values, and they want their families to do the very best they can to make the decisions that make the most sense. In the event that their living will or other documentation doesn't answer the question completely, they give their families leeway. And so I share that with you simply to suggest that it shows you how important it is to have these conversations with their families so that they can get as much guidance as they can when they're making these difficult decisions. Yes, over here.
What if there's a contradiction between law, ethics on one side and the current version of some religious directive
Good.
now or in the future? Which way would that be resolved in a hospital that's owned by Catholics?
So the question was, there's fireworks that can start when conflict starts to arise. If someone morally feels differently than, say, the patient and family, what do we do next? And what if it's, for example, a hospital policy that doesn't align well? Then what do we do? So let me read what the religious directive put out and revised in November of 2009 around the religious directive number 58, which is specifically the one that would pertain here around artificial nutrition and hydration.
Who put it out?
It was put out by the Catholic bishops who were doing their best to interpret the current stance of the Catholic Church and the Pope. Okay? Now, why do I add all that? Because this is interpretive. We don't know how a court of law would treat it, but I'm going to share with you some things that I think will help clarify some key points moving forward, so stay tuned. This is Religious Directive 58 through the ERDs for Catholic Healthcare Services. In principle, there is an obligation to provide patients with food and water, including medically assisted nutrition and hydration, for those who cannot take food orally. This obligation extends to patients in chronic and presumably irreversible conditions, for example, persistent vegetative state, who can reasonably be expected to live indefinitely if given such care. Medically assisted nutrition and hydration become morally optional when they cannot reasonably be expected to prolong life, or when they would be excessively burdensome for the patient or would cause significant physical discomfort. For example, resulting from complications in the use of the means employed. For instance, as a patient draws close to an inevitable death from an underlying progressive and fatal condition, certain measures to provide nutrition and hydration may become excessively burdensome and therefore not obligatory in light of their very limited ability to prolong life or provide comfort. All right, I wanted to read that to you because I didn't want to make anything up. That's what Religious Directive 58 says. So hang on, guys, with the hands. We'll get there. So back to your question, you first have to decide, is there anything in conflict here? So did anything I just read suggest that as a physician, I would not be able to, in fact, remove this gentleman's life support and support a natural death? Did anybody hear something that worried them? All right, so we got some hands up. So let's let you, since you asked the question.
My question was not so much for the current situation, which we obviously see is very dynamic. These things get rehashed
Retooled.
every time the Pope feels differently. But as a general principle, if there should arise a conflict.
So, in the event of conflict, which, by the way, so I've been at St. Joe's now for the past 6 years, and I've had physicians working for many more years than I have, and I have yet to see a conflict that would ever not be resolved immediately in the hospital at the bedside, including since the time when these directives were implemented in 2010. If there was a conflict that was irresolvable, what would be the next steps? If there was truly a situation where there was no resolution at the bedside, which again, I have yet to see, that patient would be moved from that hospital to another hospital. And if it wanted to be pursued in court, a judge would have to then take the information and decide.
Yeah, but what if moving them puts them in a different position? You know, I mean, they should be there from the start in another hospital.
So the idea would be, why would we ever put them in that hospital to start with if that was likely to happen? And I think one of the reasons we've never seen this happen is that in general, these cases, I can't even make them up to make them happen. And I can tell you that I've cared for hundreds and hundreds, thousands and thousands of patients who have died, and I've never yet seen this conflict arise. So if we're talking about a true conflict.
Meaning a conflict where the hospital thinks, the conflict we're talking about is that I think people are worried about is where the hospital would refuse to withdraw.
Exactly. So where the hospital would say,
where the family or the patient, if possible, wanted to.
Where the hospital would say, you have to have artificial nutrition and hydration, or you have to remain on the ventilator.
Or on antibiotics.
Not only does that not happen, in fact, every day we see the opposite happening. We see the hospital going out of its way to accommodate the physicians and the medical teams supporting patients and families to make the best decisions for patients and families. And again, not once have I seen that come into conflict. Go ahead. I'm going to let you finish because I know I want to try and get to this.
I understand that I've been here before, that, well, if you don't like it here, go somewhere else. How practical is it to be moved somewhere else? For two reasons. One, what hospital would want to admit someone in that state? And second, how practical, I know I've had operations where I counted 9 tubes and wires coming out of me. Is that really reasonable to move a patient in that situation?
So the question was a good one, which is how and when would we actually want to move a patient who's in the condition we're talking about? Well, notice, for us to even imagine a conflict, it could not be a person who's terminally ill on a ventilator in the ICU. In fact, there's no question around a person who is dying, these issues are not arising at all. It would be, in fact, a person who's in a persistent vegetative state who, as you'll discover, are not in the hospital. They're almost never in the hospital because most of the time they're living life because they're able to, and the only thing that's sustaining their life is the tube feeding.
But that's under present edicts. I'm thinking future edicts. Suppose the next pope does something radical.
I can't speak about future edicts, guys, because I don't know what's going to happen.
So in general, it's not specific. Specifically today, not so bad. I'm worried about tomorrow when the church does some left turn.
All I can tell you is, as long as you have people that are passionate about providing people with the best care possible, you're not going to see stuff like that happening. If stuff like that did happen, then I think very quickly we would see big changes, including changes around what access people have around the hospitals that they receive care for.
But the issue of moving a critical patient, please.
So the issue of moving a critical patient in general is a critically ill patient we move all the time. It happens across Denver right now, but we try to avoid it. The sicker they are, the less likely we would ever move that patient because there's an issue of medical stability. And at some point, if they're too sick, we simply don't move them. And in those situations, it would not be an option to move that patient. But again, the types of situations that I'm talking about where this could actually happen in terms of the conflict are not those patients. Those patients are dying. Those patients are imminently dying. And the Catholic Church is not stating anything around the removal or the provision of life-sustaining therapies. They're saying that's a decision between a family and a doctor. And that's exactly correct. So I want to give you a chance, and then we'll go there.
Well, I believe.
I'm sorry, I can't remember all the people that raised their hands, so I'm doing my best.
I believe you've answered the question that I was going to posit. Suppose the patient's sister comes back from New Zealand and says, no, my brother wouldn't want this. And Dad, I never liked you in the first place, but my brother told so. And so the sister said, no. The father said, yes, I've talked to my son. And did you answer that question?
So the question is, what if there's a conflict in the family? What if one family member says, well, I know that's what John would want, the other one says, no, I think John would want this. What do we do? So does that really happen?
Yeah.
You're darn right that happens. It happens all the time. And one of the reasons palliative care teams exist is to help families begin to understand how we can find some resolution to that. In my experience, when family members disagree, it's often because they're in very different places of grieving the loss of their loved one. Sometimes it may be someone coming from across the country that didn't know how sick mom was, and that mom hasn't been mom for many months, talking with the other sister who's been caring for mom and watching for the last 2 years her mom slowly dying, a death from advanced dementia, for example. And the palliative care team would begin to understand from the different family members' perspectives, what have you experienced? What do you understand about what's happening to mom right now? What do you understand about her illness and what her options might be? And by navigating those very complex, emotionally charged conversations, we can almost always find a place for the family to find some common ground and some agreement on which to move forward in terms of the medical care. From a legal standpoint, it depends what state you're in as to how the state advises us to view the hierarchy of decision making. The very best thing you can do for yourselves is have a medical durable power of attorney. What is that? That's a document that states if I can't make decisions for myself, this is the person I want to make decisions. Once you have that, it doesn't matter what state you're in, you're protected. That's wish 1 under the 5 wishes, for those of you who are familiar with that document. Any legal document called a medical durable power of attorney will suffice. If you don't have that, Colorado has an interesting little law. It's called Colorado proxy law. And what that states is in the event that someone doesn't designate a person ahead of time, as a physician, I would give the family and the loved ones the knowledge that our state states that you bring together all interested parties. And those interested parties then decide and appoint a proxy decision maker, who from that point forward will be the person responsible for making decisions. This actually works pretty good. When people first heard this, they said, wow, that sounds really weird. The reason Colorado did this is because back in the 80s, when HIV and AIDS was really coming on the scene, they learned that some of the people that were very sick were very estranged from their families. And it probably didn't make sense for their families to make decisions as much as the person who had been a huge part of their life for the past decade. And so the law came into place for that, but it's remained since. Other states have a hierarchical system that says in the event someone's sick and they can't make decisions for themselves, you go to the spouse first, then you go down to the daughter or son next, and it gives you specifies who and in what order you make decisions. Colorado does not have that, okay? So the answer to your question is the most important step would be to bring this patient and family together and try and find common ground. And in my team, we would do work like that. The next thing we would do is be looking at least putting the structure together as to how decisions would be made. All right, and then back here and then over here.
Okay, I just want to understand the procedure. So the medical team and the family concur that we're going to stop life support. Okay, but then is there some higher power that has to rubber stamp it, or can you just do it?
Good. So the question was, all right, so this family and the medical team have made the decision that in this particular case, and I'll call him John, John no longer wants these therapies. They're not helpful to John, and in fact, John would want a natural death at this point. And the question was, well, then does the hospital intervene, or do we have to check this out with the hospital, or does it just proceed? It just proceeds. Once that decision is made, the medical doctors, along with the family, make the decision as to how to ensure comfort and how to manage the expectations around that process. For example, bringing in hospice care, or making sure that the patient's going to be transferred to quiet, private room and wants music and photos and things like that, that we help create that happen. But our steps then are not guided by anyone except our continued interactions with the family around what the goals are. And that's it.
You touched on it. What is the difference between palliative care and hospice, and where does one go from one to the other?
I didn't plant her, I promise. What's the difference between palliative care and hospice, and where does one go from where does one start and the other start and stop? Palliate means to ease or relieve. That's its root. Palliative care is care that supports patients and families who are facing difficult illness. It's often near the end of life, but not always. Sometimes it may be many years from the end of life. And all the challenges that come with that. Those are emotional challenges. Those are physical challenges, like symptoms and pain. Those are practical challenges. Those are spiritual challenges. Those are intellectual challenges. I work on a team because we recognize as people are facing advanced illness that oftentimes a doctor's prescription pad is actually not that helpful. What's more helpful is someone attending to the needs of myself and my family and understanding those needs and being willing to sit down and listen to the things we're struggling with and then bring resources to try and support that, support solutions to those challenges. Palliative care also offers people choice. The fundamental principle of palliative care is respect for autonomy and recognizing that the good death, quote unquote, is so subjective that it's a silly term. In fact, the way in which people want to live their life at the end of their life is very, very specific to who they are, to their beliefs, to their cultures, to their preferences. And palliative care says, for us to provide good medical care, we need to understand you a lot better. So, hospice also shares that philosophy. Hospice says for people facing advanced illness, how can we improve their quality of life, and how can we support reducing suffering as they're nearing the end of life for people facing advanced illness? Same philosophy. Where do they differ? Hospice is further defined by the Medicare benefit. Now we're talking very practical. And the Medicare benefit says, for me to be eligible for hospice care, two things have to happen. What are those two things?
Doctor's prescription.
My doctor has to say, you don't need a doctor's prescription, but you need a doctor's order. The doctor has to say that if the disease takes its natural course, I would expect this person to die in the next 6 months. So notice, someone who's got 2 years to live is potentially not eligible for hospice services, but they may be very aligned with the comfort approach of hospice. They just don't have access to the services because of the Medicare benefit. And by the way, all other insurances mirror that. So whether it's Aetna or Cigna or Kaiser or whatever, they all mirror the Medicare benefit in that 6 month
How do you
rule.
look at someone and decide they're going to live 6
Oh my
months
gosh,
or
what a
10
great
years?
question.
My dad was on hospice for 7 years. It's bullshit.
So,
Clean it up, shut up.
yeah, actually, for respect for the whole group,
Yeah.
let's try and, again, these are very good points, and I want to address these points, but let's make sure we keep our heads together. So, can we predict when end of life is?
Somewhat.
So, you guys are answering it
No,
perfectly.
anyone that answers yes, I'd like to hear them.
So the answer is, somewhat, is a pretty good answer. In that, if I'm in the ICU, there are things that I can do to detect whether someone's actively dying. They have modeling in their skin. They have changes in cooling. There are things that tell me when they're actively dying. But as you know, active dying doesn't do much for us when actually what we're interested in is when is the last year of life. When people are in the last year of life, then how do we begin to know whether someone's kind of actually coming to the close of their life? Well, there are some studies that help us in terms of understanding the types of disease they have. If someone has advanced cancer, for example, that's metastatic, that means it's spread across their body, and they have metastases to the brain, and the underlying cancer is pancreatic, I know if I lined up 100 people, 99 of them will be dead within 2 months. Does that mean I know that that one will be dead, that one person? No. But to say we don't understand that that person is dying is also probably not correct. So that's why I say there's that somewhat. Now, there are other diseases though. In fact, the disease that many of us are probably at risk for dying from, which is heart disease. When people die of heart failure, they actually have a much different pattern of death. It's not one where they are doing well and then they decline, and with cancer, as they become bedbound, we know they're coming closer, and they may have weeks, and then after they stop eating, they may only have days. It's not like that. With congestive heart failure, those people have a trajectory of illness that shows they have these exacerbations. And you've heard of people describe this worsening all of a sudden of their emphysema or their heart failure. When they have that worsening, they may in fact die with that exacerbation. Despite going to the hospital and everyone doing everything they can, they may die from, or they may recover and go back home till the next exacerbation. And in between the exacerbations, they're doing great. So how do you figure out when that person's going to die?
What's the exasperation?
Exacerbation just means that the disease has this natural cycle to it where they have good times and then they have bad times. And they'll usually die during one of the bad times. It's often caused in heart failure because they a subtle change in the medications, or they had too much salt over their Thanksgiving dinner. There's lots of things that can trigger an exacerbation. Infections can trigger it. So the message I'm trying to make is we don't have great crystal balls, but it's not that we don't have any crystal ball either. There's something in between. And for when we're trying to figure out that 6-month window, fortunately, Medicare recognizes that doctors don't have a crystal ball. They do their best. And that means if you admit someone to hospice care and 3 months later they're doing great, do they get kicked out of hospice? No, as long as we continue to recertify them, we recertify them every 6 months, we ask the question, if the disease takes its natural course, is this person likely to die in the next 6 months? If the answer is yes, they're still eligible for hospice and they're still on hospice care. The longest I've ever had someone on hospice care was 3.5 years. I've actually never heard 7. That's even more impressive. But the message, you guys, is that Medicare is not limiting people to 6 months of hospice. They're just trying to identify the patients who are typically in the last part of life. Now let me ask a question that I have to ask that mirrors that. What's the median length of stay in hospice? So 1 week, 2 weeks, days? 20 days. The median is 20, meaning most people get about 20 days of hospice services. 1 in 10 get less than 1 day. And then a smattering of people have these very long hospice stays. I share that with you because, again, the challenge our country faces when people talk about accessing hospice care is not because of the issues around this inappropriate long length of use of hospice. It's actually, in fact, because patients, families, and providers often utilize hospice services fairly late relative to where they could be utilizing them. Okay? I think we got yours. So here, yes. Go ahead.
Exempla was recently purchased by the Sisters of a Catholic organization. If the hospital was required to make a decision on one of these cases that you described, wouldn't there be an entering bias?
They don't make the decision, that's what he said.
So there is no decision making by the hospitals at the bedside, so let me be clear of that. The only way a case like this would arise to a situation where...
Didn't hear the question.
Oh, I'm sorry. So the question was, actually I'll let you pose the question.
Wouldn't there be in the beginning of the discussion, the beginning of the debate, basically between people in the hospital and others, doctors, etc., wouldn't there be a bias on the part of the representatives of a Catholic hospital toward keeping the person alive?
Good. So the question was, in the event that this were to arise to a situation where we had to actually say take it to court or take it to higher levels, would there not be a bias on the part of the hospital around, in fact, the fact that the moral directive is in place? And the answer is clearly there would be a bias. However, if it were to ever arise, how would it arise? How would anything like that happen? The only way that would happen would be if someone brought a lawsuit upon the hospital because they were refusing to provide a therapy or refusing to allow a therapy to not be provided, either direction. And the question is how often do we see that happening? Well, we don't. Could it happen? Absolutely. And if it did, notice that from the religious directive standpoint, one of the challenges they would face is, are those religious directives legally? Are they in conflict, in other words, with the legal system? And that we don't know the answer to. We wouldn't know the answer to until, in fact, went to a court of law. But what I can tell you is, again, I really don't want you guys thinking about that as much because, again, I've been doing this a long time. I've never, ever seen it. What I see is every day caring for patients and families, and I see no conflict ever. So I just want you to keep in perspective where this falls in terms of, yes, we can come up with some hypothetical cases. And they're legitimate and appropriate for us to be discussing. So let's go over here.
I think it's a corollary, and you may have already answered it, but who defines excessively burdensome? Because that's where it always comes down to is language definition.
I love that comment. Who defines excessively burdensome? So if I was to poll you guys, if you had advanced dementia and you were in the last year of life and you got to the point where you could no longer eat, you couldn't feed yourself, and in fact when people try and feed you, you clench, how many of you would want artificial nutrition and hydration? Raise your hand if you're willing to share. How many would not want artificial nutrition and hydration? So this room is actually biased a little more than the general population, but not much. When you ask the general population that question, about 80% of folks will say, I would not want the provision of medically assisted nutrition and hydration in that context. And about 20% say, no, I would actually want that. It would depend a little bit on their quality of life as perceived by their family and other things. But I share that with you because that's the predominance in this particular case of saying for that group and for what I just polled you guys on, you felt that that therapy was in fact not meeting your needs and was excessively burdensome. Could someone come in and say, well, tough beans, we're going to stick a tube in you anyway?
Yes.
That's our fear.
What do you think?
No.
The answer is no. There is no yes in this room right now. This is not happening in our society. This is not happening at any of the hospitals that I'm referring to today. And in fact, the religious directives, in fact, make it clear in situations of advanced and terminal illness. By the way, people with severe dementia die because of infections, and they die as a result of the natural process, which includes, as they go further in illness, not being able to swallow, losing their appetite completely, and not wanting food or water, including the clenching I talked about, including the inability, even if we tried to feed them, to help them. In fact, in those people, if I was to instead say, listen, I'm going to put a tube in you, and I'm going to put that tube in your stomach, or I'm going to put that tube in your vein and give you IV fluids and food, and if I were to compare them to those who don't, they don't live any longer. They don't have any different rate in terms of infections. We sometimes put it in because we're afraid they're aspirating, which means that when they eat, they choke and they get pneumonias. Well, it turns out when you put a tube down here, they still get pneumonias. In fact, there's some studies that suggest they may die earlier with the tube feeding or with the IV fluids because of the fluid that you give them and because it increases the risk for infection. So why am I sharing that with you? Because medically, it's hard to argue that it's even indicated. In fact, it's probably not indicated. So in that situation, the directives aren't saying we have to give people things that are not medically indicated or in fact potentially harmful. And in that situation, I can tell you, you would find very few physicians who in that situation would probably even advocate for it. Now, it's very dependent on that own physician's experience. You'll sometimes meet people who don't know the data I just shared with you. They don't know the fact that when you compare people with dementia that are on those therapies versus not, that actually there's no benefit. Because they, like many of us, think, well, if you feed them, they must live longer, right? It seems that way. With advanced cancer, with most advanced cancers, it would seem like if you feed someone when they're not eating and they're cachectic and they're wasted away, and they're looking really, really thin and they only weigh 80 pounds, that if you feed them, it'll help, right? It doesn't. And that teaches us that we don't know that much about the body, but when we actually start to study, we learn that one of the things that happens is the body takes care of itself in the dying process. And as it starts to shut down, part of our brain called the hypothalamus starts to turn down so that we don't feel hunger or thirst. In 1994, they did a study in a palliative care unit. It was published in the Journal of the American Medical Association that showed people were not reporting hunger or thirst. And in fact, if they had any hunger or thirst, if you gave them some ice chips, they felt better immediately. But what they really were struggling with is their families really wanted them to eat. Their families really wanted them to drink, and they didn't want to. And it was teaching us, again, how the body begins to take care of itself. Yes?
If the question had been, what is the meaning of excessively burdensome? It seems to me that whether you artificially feed someone is more, and the way you responded was more about the quality of that person's life. But excessively burdensome, isn't that more than just on the person? It's on the family. I know for me, I don't want to see my son's eyes showing his heartbreak when he can't relate to me or I can't recognize him. So
Right,
who
so-
are we looking at as far as the burden on whom?
So, again, I'm not an expert on the directives, but I'll tell you that they do not explicitly state the excessive burden part. But what they do make clear, and I think this is actually the area that is worthy of causing the most pause, is that to state that the life has become excessively burdensome, meaning the act of living for a person with persistent vegetative state, that they would not want to live that way because it is of no life, it means no life, is not sufficient. And this is only for persistent vegetative state again, you guys. This is not about dying patients, which are all the people we've been talking about. That in fact, you'd want to, they would argue, demonstrate that the excessive burden has to do with the therapy. For example, putting that tube in, and in fact delivering fluids that are constantly giving them infections and facial swelling and other problems that in fact make it more burdensome than helpful. And in those situations, again, they don't claim there's an obligation. They simply say there's a moral predilection towards providing those therapies in persistent vegetative state versus not, in the absence of that type of burden. What causes me to pause, though, is that for many of us, I know in my experience, I would look at that and I would say, to me, that just doesn't feel like life worth living. And the burden, in fact, is in part because I would already have witnessed myself coming to the end, meaning the moment I'm in that state, I can't feed myself. I can't give myself water. So, in fact, if this was 100 years ago, I certainly already would have died. So, is that not terminal illness? And I'm not going to answer that today because, believe me, that's the debate I get into with them. That's the piece. But again, do I see that? Is that playing out in our society right now? No, we don't see that happening. Yes?
In the last 2 days of my father's life, he was actually in a position where if he were my brother cared for him exclusively for 7 years, okay, unprecedented in Boulder, according to his physician, my dad's physician. But in the last 2 days, when my brother wanted to do something that required a nurse to come in and give him something, they said that he would have to go off hospice in order to get that care. My brother had to make the very difficult decision, and between my two brothers fighting about this, my one brother who's the younger brother who's a Buddhist and wanted to let him go, and my brother that had been exclusively caring for him, wanting to do everything he could. And the brother that wanted to do everything he could had to make the decision for my dad that he couldn't get this nurse in to get him the things he needed to continue, based on his need to continue his life.
What's the question?
So how do you debate that? Not having hospice. I thought hospice was supposed to be at the end, when in fact hospice went away at the end. And the reason that my brother made this decision was that my father liked and was used to the hospice person. Exactly the kind of things you're saying. Someone that was close to him, that related to him, and my brother thought that my dad wouldn't want to give that up.
I've got to give everybody else a chance to participate. So let me just answer that question. The way the hospice benefit works is the second piece we didn't answer, and I realized it was a good reminder actually of not answering the second piece. So remember I said the two things that have to happen? The first thing we talked about was my doctor says I have less than 6 months. What's the second thing? I have to waive further curative therapies. Now, curative, as you can quickly see, is going to become subjective. But if someone is in fact receiving hospice services and then says that they want a therapy that would involve, for example, someone going back to the hospital or to the ICU, or they want a therapy that's not traditionally covered under a comfort approach, at that point, again, artificially, the Medicare benefit would say that person's no longer eligible for the hospice benefit. Do I like that? I hate that. But the truth is they have to figure out how to administer this benefit somehow. So what they're trying to do is align the people who are nearing the end of their life, who want a comfort approach, usually in the home. 85% of people receive hospice care in their homes. They're trying to align that benefit to allow them to stay at home and to provide those services and to develop the kinds of relationships we heard. However, I want you to see it's not perfect, because it can break down because of the fact of that eligibility requirement. And what I'm trying to do is create palliative care services nationally right now with the organization I work for to make sure that wherever you are in the continuum of wherever your illness is and wherever you may be residing, that you have access to a professionally trained team that can support you and your family regardless of whether you meet some criteria or not. That's an enormous task, and we're only partway there. And I want to share with you that's an important piece of what I want you to walk away with today. So here, and then these two, okay, and then we'll go back.
We're assuming what you've spoken about is sort of ideal, the families there, the hospital and everything. What about people in nursing homes? I have two examples of very good friends whose husbands were in the nursing home, and the nursing home did not pay attention to the directives. They called the emergency, that a person was taken in, put on ventilators and everything.
It's awful. It's awful.
You know, and then it's a matter of taking that person off the so-called life-saving thing. But primarily, I'm concerned about what is Kaiser's. If I look through the book, we have nursing home care through Kaiser. I guess the hospital, the doctor comes, whatever. How do they handle that?
So the question for those of you who may not have heard was specifically issues around the care in which people receive in nursing homes. And the story she shared was examples of where people had directives, but the nursing home perhaps didn't know or ignored those directives, and the person ended up over in the hospital on a ventilator and later had to be taken off of life support. We hear these stories periodically across our country, and they happen in part because of the fragmented care that's provided, not just at end of life, really throughout our care system. And it's not specific to any insurer, it's not specific to any care system. We see that fragmentation across the country. That's one of the reasons why they're trying to make changes now to our healthcare system. And unfortunately, we haven't been too successful in doing that yet. But I want to come back to, in Colorado, one of the things that's new that you may have heard about is MOST. And Ray, if your group hasn't done anything with MOST yet, you should. MOST stands for Medical Orders for Scope of Treatment. One of the things that's going to be happening both in Kaiser and throughout the system is the implementation of MOST. And what that is physician orders around the therapies a person would or would not want when facing advanced and terminal illness. And these orders are actually carried with people to the ERs, to the hospital, to the ICUs, to the nursing homes, to the skilled nursing facilities. Generally, for ambulatory people that are many years from the end of their life, these orders probably aren't apropos or necessarily the direction I would recommend people use them. These are really designed more for people who are much more likely to be close to the end of life and in and out of facilities where you need to really deal with that issue. Kaiser is actually in a position where we're re-looking at all of our end-of-life care in the nursing homes right now. And for those, how many are Kaiser members here? Just for, wow.
That's why we're here.
All right, well, fantastic. I won't feel shy. Kaiser, you guys, Kaiser, Colorado has probably the best palliative care in the country. We have phenomenal palliative care in that we offer services that other places don't offer. We have inpatient palliative care at our hospitals. We have 2 teams at one of our hospitals. We have weekend coverage, which most hospitals don't have. We have a full team where a nurse, physician, social worker, chaplain, and pharmacy are all paid for. That's almost unheard of across the country right now. We have a home-based palliative care program for people who are homebound and not able to leave their homes, where a team will go out to them. And these are patients who are not yet ready or eligible for hospice care. And we support them wherever they are in their treatment, for their cancer, or for their heart failure, or for the other diseases they have. We have a new palliative care clinic that just opened up at Rock Creek, where you can see for ambulatory patients, you can go see a physician, nurse, and social worker and have a consultative model where they support the care that your other medical teams are already providing. We have social workers across our system who are trained specifically in supporting patients and families in the last years of life to help complete directives, to help understand the caregiving burden at home, and to help find solutions to try and make that situation better. And we're examining this year some programs for the nursing homes. In fact, my new role as of 2011, one of the things I'm going to be doing is trying to develop a better palliative care system within our nursing homes. Right now we have a program, again, unique to Kaiser, Colorado, called Kaiser Special Services, where patients and families have access to up to 15 visits with a hospice-trained nurse or social worker for times when they're not yet hospice ready or eligible, but they in fact just need information around the challenges that their loved one may be facing in symptoms, or challenges their loved one may be facing in terms of understanding, well, when would the timing to hospice care be right? And these people can help families navigate that system. With all of that in place, we've still got gaps, and we're still not where I think we need or want to be. But if you compare that to where other people are right now, those services that I just described are not covered under Medicare. Okay? That's a Kaiser benefit, everything I just described. Now, in hospitals around the country, 60% of hospitals around the country do offer access to palliative care services, and they're variable, and the physician on that service can still bill Medicare. It's just that typically don't have a social worker, a nurse, and a chaplain with them because those people aren't getting paid underneath the Medicare benefit. There are very few home services, but for those of you who don't have Kaiser, I want to share with you, there are what are called hospice bridging programs. These are typically through our hospices, and there's multiple hospices locally that provide them. Hospice Care Boulder, Broomfield does, the Denver Hospice does. They provide services upstream of people who are typically on hospice care. So they either may not be ready to give up their curative therapies, or they may in fact have a life expectancy that's many months more than that 6-month measure. And in that situation, they can provide some team support, usually nursing and social work support in the home, to try and help people to understand as they move forward how their decisions and their preferences for treatment will be honored, and how to help support moving them to hospice care, to that type of hospice support as that becomes warranted or best fitting of their needs. So those are services that are available. So for those of you who are wondering about, where should we be going with our end-of-life care, I think we should be working to create a system that, again, provides access to the types of services I just described wherever people are. And if you or a loved one start running into troubles, I would say don't hesitate to outreach to programs as you see they're available. On the last page, down at the bottom in terms of the resources, I gave you the 2 phone numbers for the hospital-based palliative care services, plus the phone number for the clinic, which can link you to the home-based program as well. So if anybody has questions around that, there's some additional resources there. Hang on, I think we have to go here, and then back there.
Okay, I'd like to return to the,
If you sit in the front row, you get the mic.
I'd like to return to the conflict between relatives.
Between what?
Relatives.
Oh.
Relatives in making end-of-life decisions. Many years ago, my mother was in a nursing home, severe dementia, not caring for herself at all. And she developed pneumonia and was sent to the hospital and then released back to the nursing home. She was living with me, and my 2 sisters were involved in discussing her condition. We had a much younger brother in Florida who was not estranged, but very little contact. Then when she developed pneumonia again, her attending physician said we could take her to the hospital in maybe another couple of days. My 2 sisters and I said no. And my brother, we felt, would have said, save Mom any costs at all. And so we simply didn't tell him. And I don't feel that that was unethical or unlawful, but it certainly was exclusionary. And we never considered having a telephone conversation and trying to persuade you.
So I'm glad she shared a fairly complex story and some dynamics. And in this particular case, the sisters made the decision to say, let's just proceed. And this family member then, in the process, the son, the brother in this case, was not a part of that. I would encourage you guys, as you're facing these challenging decisions, or you see families, other families that you know that are facing the decisions, again, to not be shy about bringing a palliative care team in. I relish situations like that. I live for situations like that because in my experience, I can bring families close together. I can help families to focus on the empty chair and help make decisions that are consistent with everybody and everyone gets a chance to be heard. But it's also a fine example, I think, of a myth and misperception out there. With advanced dementia, which, by the way, as we get really good at curing all these other diseases, do you know what we're leaving ourselves with? That's how we're going to die. And for a lot of us, I'm thinking that heart attack ain't such a bad idea. But if you're facing that, it reminds you how important it is to have your directives in place. Fred Abrams, how many of you guys know Fred Abrams? He's a wonderful doctor and ethicist in town who wrote a book called Doctors on the Edge. And one of the chapters in his book, if you've never read this book, it's fabulous, is about a woman who prepared her directives ahead and said, when I'm no longer able to recognize my family and I develop a pneumonia with my dementia, let me be clear. Do not bring me to the hospital. Do not give me antibiotics. And please let me die naturally of pneumonia. By the way, how do people die of dementia? Pneumonia, number one. She said, that's when I'll know it's time. And the ER doc was really uncomfortable and didn't know how to deal with that. That directive was very puzzling. This was many years ago now. Well, that type of directive these days is incredibly valuable. As they call me, the palliative care doc, down to the ER, if that person even ended up in the ER. And the good news is now, many of those patients are being identified early. They're linked with hospice services, and 911 is never called. In fact, the hospice team is called. The hospice team comes and provides oxygen and provides some medications to help with any breathing difficulties and allows the patient to die naturally. But if that person was to show up in the ED, I would say, why is this person in the ED? We need to get them back home. And we need to link them with hospice services so that they can be comfortable in this process, as this pneumonia will either clear or in fact they'll die from that pneumonia. But again, it's the natural process that they've already told us clearly they want.
What's the name of the book again?
So it's called Doctors on the Edge, and the author is Fred Abrams. He's a retired OBGYN physician here in Denver.
He spoke here.
He's awesome. He's like one of my favorites. All right, so back, I think one of you guys, yeah.
So it seems clear morally when people are really right on the edge of dying, but what about several years out? Let's say you're diagnosed with a cancer that is inevitably going to lead to an agonizing period of time. How does the palliative care ethic apply to decisions? I think a lot of us think about that, or for dementia. I like what you just described, but are there other ways that would help somebody shorten that whole process?
Yeah, so I think the question is how do we play with the mix of therapies that are available for people, especially as we move upstream? Maybe they're not in the last weeks of life or the last hours of their life, but they have more time to live. And how do we navigate therapies in that situation? I will speak for myself as a physician and a member of a palliative care team, and I can speak for my field to say that as a result of that definition I shared with you, easing or relieving, one of the most important steps is to understand what is the person trying to achieve? What are their goals? And sometimes their goals are, I want to live as long as possible, no matter what. It doesn't matter how much suffering occurs. That's very unusual. Much more commonly what I hear is, well, I want to live as long as possible as my quality of life is okay. But as it starts to trail off, I'm not so sure I want more therapies at that point. Can you just keep me comfortable? And then you have the other extreme of people who talk about comfort, really, and even if they got the most slightest infection, they wouldn't want to treat it, even if they had potentially a couple of years to live. Don't hear that very often either, but sometimes you do. But that spectrum highlights for us the fact that people have very different preferences about the therapies they would want or not want under certain conditions. And what the palliative care team does, what palliative care teams do, and what good medical teams do, it doesn't have to be just palliative care, is help us to understand what you're trying to achieve. What are you hoping for? What are your wishes? What are your fears? What are your hopes? And then let's develop those preferences around those treatments. And in no circumstances, if someone refuses a medical therapy, whether it's an antibiotic or a ventilator or tube feeds or transplant or bone marrow transplant or dialysis, wherever you are in the system, you are controlling the shots, period. And if you don't want those therapies, those will not be given, forced upon you, or even pursued further. What I can tell you, though, that we see much more of is the opposite. So let me briefly talk about the opposite. That is families and patients who demand everything, even when those medical therapies are likely harmful. What do I see some of my doctor colleagues doing, not in palliative care, but in regular medicine? Sometimes is they provide those therapies because they're afraid of being sued. When in fact, the courageous thing to do is to say, my oath said first do no harm. I realize you want that therapy, but that therapy will not help Bob. That therapy will actually make Bob worse, and I can't provide that therapy. I rarely see that conversation happening in medicine, but I want to share with you that flip side conversation is actually far more common than the situation of someone who is saying, I don't want dialysis. Because right now in our system, if you say, I don't want dialysis, you don't get it. I don't want that antibiotic, you don't get that antibiotic. We will honor whatever request you're making in that direction.
Would you make an effort to be sure the person understood?
Yeah.
That, I mean, that's an informed.
Yes. So this little funny thing called informed consent was the comment. Would we make an effort to make sure it's understood? In fact, people are often surprised when I'm talking with elderly folks. I just had a man last week who was in his mid-90s who said, you know, if I got to the point where my heart stopped and my lungs quit, I want you, I don't want to be resuscitated. And most doctors, when they hear that, is great. They sign it and they leave. I said, John, that's not his name. John, I want to learn more about that. Tell me why you're making that decision. I wanted to know what he knew about resuscitation. I wanted to know what he knew about his illness to see if actually he was making a decision that was informed around those pieces or if there was another story behind his decision. In his case, it actually was very consistent with his goals, values, prior preferences. Everything was aligned. But I want you to know I've had the exact same conversation with a 20-year-old girl who was saying that. And I can see now most doctors are not going to let that one slide. And so when we explored that, she had had asthma and had been several times where she had been on the machine, and her experience on the machine had been awful. She had been breathless, she woke up, she was confused, and she saw this tube, and she had actually pulled it out twice, and they had to stick it in again. She said, I'm never going to go through that again. And my conversation with her was, I don't blame you. And I also shared with her what the normal looks like when people do it correctly. And in fact, attend to a person who's on a machine, and in fact, make sure that they're sedated, that they're comfortable, and that they're not waking up. And after she thought about it further, a day later, she said, I want to talk to you again, Dr. Johnson. I think maybe I would want this in the event. And I'm not suggesting that I overturned her decision. I was trying to make sure it was informed. I was trying to make sure that she understood what had happened and that she didn't have to accept that every time you went on a machine, that's what it was going to look like. Because that was an example of medicine that was not good for her. Did I skip you in terms of questions? Did you have one?
You answered it. I was
Okay.
going to ask, what is Kaiser's palliative care? I was a question about
Okay,
that.
good.
You really did.
And I want you guys to remember, too, that if you don't have access to palliative care, first of all, whenever you need help, you should find out what access you have to palliative care services. That's whether you're in Colorado or Illinois or Florida, because it's changing dramatically across the country. But I also want to share with you guys that when you're in these tough situations, it's very unusual for a family to be able to kind of navigate this on their own. Easy decisions and getting our directives in place, maybe we can do that ahead of time. But the truth is, when you get in the throes of these decisions, you usually are going to need help. And I would have no hesitation, I would recommend no hesitation for you guys reaching out. Yes?
An end-of-life question. We seldom hear about the cost. And the palliative care physicians discuss the cost. We will have to in the future. We don't today so much. but cost will be a deciding factor on, if the family says we want to live forever, then they should pay for it.
Yeah. So I hope everybody heard his comment. It was around medical costs. And believe me, in 2009, when the death panel stuff kicked up, and everyone was talking about the death panels and we're trying to cheat elderly people out of the care they deserve, it really upset me. Because in fact, what I've learned in my own system and in working in hospitals and in Colorado for many years is doctors don't practice around costs. Doctors practice to support patients and families in the ways that are most useful. Well, one of the reasons I started doing palliative care is because of a whole series of studies that began to teach us that when you actually take the time to sit down with a family and listen to their concerns, and whether that's in the outpatient clinic setting, or that's in the inpatient setting, or if it's in the nursing home, and actually treat them as people, who they are, with loved ones and family members that have desires and hopes and dreams, that actually as you begin to learn what therapies would make most sense to them under certain situations, you learn that most people are very reasonable. And most people, in fact, don't want to spend the last 3 weeks of their life in the ICU on a ventilator. And that's not to say that some people might not, and if they do, our society right now provides those therapies. But the mistake we get into is automatically providing those therapies to people who have diseases, instead of taking the time to learn who is the person that I'm talking with and what would actually make most sense to them. And when they want to be at home, creating services in their home to keep them there, which, by the way, is a lot cheaper than sending someone to the ICU and having high technology services at the end of life. So what we learned is that investing in these palliative care services actually pay for themselves. I can easily afford to have a team out at someone's home if that's where they want to be. Or if they come in and say, I really want to be on that machine right now. For right now, we're paying for that. I think you're right. I think our country is going to have some very difficult conversations coming to say, right now, anybody can walk in the hospital and demand everything if they want it. Perhaps in the future it may not be that way, but it is right now. Someone over here had, let's try back there, I think, and then up here.
Can you tell me about how available terminal sedation is?
So the question was, how available is terminal sedation? And terminal sedation, for the most part in America right now, is rare. What terminal sedation is as a palliative care physician or even as a medical clinician, I'm going to do everything in my power to get your symptoms under control or your pain under control in the event that you're struggling with that at the end of your life. And if despite that, despite me doing everything I can and calling colleagues around the country, I can't get it under control, the idea is, well, let's at least put them to sleep. We won't take their life, but by putting them to sleep, at least maybe they have less suffering. You can imagine, we can't study that, so we don't actually know if that's true. But if that were true, the idea is let's put them to sleep and allow then the terminal illness, usually in the last days, to just take its course while they're asleep. Well, the reason this doesn't happen very often is, first of all, there's all sorts of ethical challenges that people have placed. Though right now there's certainly no legal barriers to us providing terminal or palliative sedation, and it does happen periodically. But I think the reason it doesn't happen, and it hasn't happened in my career, is because if you're really good at managing symptoms, I haven't needed it. I've been able to work, whether it's a psychological or emotional symptom, with the teams that we have, or more commonly with intractable physical symptoms. I call my connections around the country. I say, how would you handle this? They say, try ketamine, do a little bit of IV lidocaine, see if that works. So we try different things and we're usually able to get people comfortable. That said, if you look at the patterns of what happened in Europe, palliative sedation is actually quite common in Europe right now. And if you look at the traditional way in which America develops its healthcare system, we actually lag behind by about 5 years. So I think we'll see more palliative sedation in the future, and probably that's a talk I'll give to you guys in the future as well.
That might not be a good thing.
There's all sorts of pluses and minuses around that piece. You guys, I'm gonna give this back to Ray. Thank you for your questions. I'm gonna stay up here. And I'll answer your questions, and I want to encourage you guys on your handouts. The last page is the summary points of everything I wanted to make. And let me just summarize by saying, since this has occurred, the directives piece, palliative care and end-of-life care at Exempla hospitals, which, by the way, it's a collaboration between Kaiser and Exempla on our palliative care teams. We have actually members from both teams available. Has not changed. If anything, we only keep growing in the services that we're creating and the access we're providing. Those two hospitals alone provide more than half of the palliative care that was provided in all of Colorado last year, and they by far lead any of the hospitals, not only in Colorado but in the whole Mountain West. So in terms of you feeling comfortable with end-of-life care in Colorado, I'm trying to tell you guys, especially those of you who have Kaiser, you're in a good place. Do not hesitate to outreach for help. The moment you bring one of these people into your story, they're going to help you navigate and make sure that all of your wishes are honored. For those of you who are worried, what if I don't have access to those services? Again, I just want to reassure you, I have seen zero change in practice at these hospitals, and the care that's being provided, it's where I would want to be for my own end of life. So I hope that helps.